I think 2 so far, but I'm gonna go on my phone too, just, yeah.
Good, just finish some longer things. Just glossing over some. What do you think?
How far out?
It is like 3 months. I think it's 40, the next one it's about there. It's just like a trauma. 3x lab. There's always, they can all get from the public market. Like, not too bad.
You putting
What's their component? Just normal stuff. Just normal stuff. I see cheaper. Oh, yeah.
Maybe I actually missed it.
They're only on friends. It's very fast. Rotation of the stuff.
So you guys can still see our screen, is that right?
Yes.
Perfect. Should we get started? Ready?
Yeah, it's because we're on currently, and it said, okay, okay, so I'm gonna get started, just
Okay.
might get pulled up.
Great. I was asked to do a second part of trauma talk. I know Dustin already went through a lot of stuff, so the first like 20-ish slides are gonna be very fast. They're just like a repeat, just to refresh everybody's mind, because I think there's a lot of information that's useful. And then we're gonna go into kind of an actual new part of the talk. I think this is a slide of just pictures that we've accumulated over the years. And I think that's kind of what we're known for, which is the trauma. You know, trauma is like the exciting part of, I think, surgery and some of the rotations, which is there's a lot of penetrating trauma, a lot of extremities that are really mangled, you know, failed attempt at suicide, again, when being hit by a train, a lot of different things, but I think that's not all what trauma is, and that's hopefully what we're gonna get at today. Very briefly, the trauma survey, when a patient comes in, and even on your test questions, say for your shelf or your step 2, you should always be looking at the patient as if, are they stable or are they not? And I think part of that is the ABCDEs of the trauma survey. So Dustin kind of talked about getting airway, make sure that they have a protected airway, otherwise we're intubating. Breathing, making sure that they have bilateral breath sounds, or that we're addressing if we think that they have like a tension pneumonia or something that could cause them to crash. Circulation, if there's any large injuries that are causing a collapse of circulation, and we're transfusing and getting access as necessary. Disability, Dr. Milburn this morning at Grand Rounds talked about disability as in disability of extremities, broken bones, deficits. So that's very important to assess as well, because that can also contribute to collapse of circulation and blood loss. And then environment exposure is, you know, was the patient exposed to anything that we need to address immediately? Like, did they come from a burning building and we're really concerned that they have compromised the airway? The secondary survey is, you know, part of the trauma survey overall, and that you're exposed to the patient, you're looking at everything to making sure you're not missing any injuries. So very brief overview. Adjuncts kind of to the survey, like I said, intubation, getting access is very important. Primarily, it is going to be large bore IVs, 2 large bore IVs, because if you think about central lines, the length of the central line as well as the caliber, so the diameter of the line, is not going to be as efficient as 2 large, short, like length or IVs for us to massively sort of just dump product into a patient. Chest tubes, like we talked about, for breathing in case they have tension. Fast if they're unstable, blunt. We don't really do fast in penetrating because I think it's a little bit of less of a utility. And then ED thoracotomy if they are penetrating less than 15 minutes, have lost circulation, or a blunt trauma who loses signs of life in front of you. That is the indication for an ED thoracotomy, not anything else.
One quick thing I wanted to add, in your exams, you have to be really careful to follow those ABCDEs, because what you're seeing in live, like in vivo, is like everything being done simultaneously. So sometimes in your mind, you might feel like this came before that. You still want to answer the questions in that order, because theoretically that's what's important. But as you know, like everyone's working simultaneously, and most of that stuff's going to be being done as one at one time. And like when you have your ATLS exam too, like you still, again, you know, order, you know, say ABCD, that order.
This is very quick. I think that no matter what specialty you end up going into, I think you will need to know how to place a central line. I'm gonna leave, this presentation is in my shared drive folder, but we're gonna just go over very quickly kind of what it involves going through a line. 'Cause I think you all have workshops that you're gonna be doing simulations and things like that. So I think anatomy is important, also just kind of getting comfortable with what you need and what to do. Central lines come in different flavors. There's a triple lumen. This is more for central infusion of products, but the actual diameter of this is very small. It's 7 French. A cordis is what you see us putting in the trauma vein is 8.5 to 9 French. Usually it's 9 French. A quinton and a trialysis cabinet. This is for dialysis access, so this is even larger yet. This is usually, you need a place that's not blinded, but under ultrasound guidance. And I think everybody should know that, the French meaning, like if it's 9 French, it's 9 divided by 3, so it's actually 3 millimeters in diameter. Because I think it oftentimes becomes very silly if people are asking you certain things and you're not sure, and it's just kind of like you learn things secondhand. So French is different than like a gauge. So like 18 gauge needle is larger than a 20 gauge needle. 20 is larger than a 22 gauge needle. So that's a different type of measurement that we have in surgery. French is just the larger the number, the larger the diameter. Gauge is the larger the number, the smaller the diameter. Right? So just put that out there.
Can you just briefly talk about like how long each of those, it's okay for those to stay in?
That will be in a subsequent slide. Oh, stay in or like length of actual like. Well,
It's kind of changing.
if you place the line sterilely, you can have it in technically as long as you need to. I think the old adage in the hospital is, femoral lines are dirty and you should change them out, like it's like every 5 to 7 days. I don't think that that's true anymore, especially if you look at the meta-analyses. So they did a study and I don't think it's in New England Journal of Medicine, but it's maybe in JAMA. But it looked at the placement of like 10,000 lines, femoral versus subclavian versus IJ. And there is no difference in infection rate so long as it's sterilely placed and maintained. And that's using fluorohexidine embedded dressings, like the biopatch, and making sure cleaning and regular line care. Obviously, if somebody's bacteremic, or has fungemia, then you should be thinking about doing line exchange or line holidays. But in the setting of an ICU patient who has a line that's sterilely placed, who's otherwise stable, I think, as long as you have the line in and it was sterile and it's clean, then, as long as you need to. Even
Flipping it out to triple lumen.
Even a cordis, if you need the cordis for resuscitation, that's fine. If you need more lumens, meaning like this line only has one line to infuse something into the body, the cordis has this inner cannula that you can stick this triple lumen through. So then you've essentially taken a cordis from 1 port to 4 ports. So that is a trick that you can do, but I don't think that there's a clear study showing evidence-based that you need to, if all of the things being sterile and the patient's stable, to exchange lines or leave them in. Obviously, leave them in short as you need to them, but if you need the line, I think you should use the line. Unless you need different.
Yeah, no, thank you.
For central lines, there usually is a kit that you'll need. The ultrasound machine should be used when you're not placing a crash line. A max barrier kit. This is just for y'all's own knowledge for like what we're gathering and when the residents are doing a line, why we do things. And this is obviously in a sterile procedure. In the max barrier kit, there's sterile gowns, face masks, eye shields, a bouffant, and tegaderms and biopatch. That's a lot. You do need sterile gloves. You need lower lock caps that helps to screw on so that you're not just having to clamp the line. This is kind of like a self-locking cap that is easy. Saline flushes or a bottle, and then extra gauze just because things do get messy. And then again, just to mention, these are kind of things you need for a sterile line. This is what's usually found in a line kit. This is a triple lumen kit. There's a guide wire, cleaning stick, some drapes for where you're actually putting the line, scalpel, some syringes, some syringes and some gauge needles, and then there's a dilator and some lidocaine. So the kit comes with a lot of things, and that's pretty standard at most hospitals. I'm not going to go over this in a crazy amount of detail because I think the anatomy, the actual back end of the talk is going to be more use, but you want to position the patient, and I think setup is always very key for anything you do in life and in surgery. So you really do want to make sure that you're positioning the patient and everything that you need is handy. The worst thing is you get all prepped in and all of a sudden you're doing it, you forgot something and no one's there to help you. So you have to unscrub, redo everything, or you have to call for help and the nurses are also running around busy. So make sure that you position the patient. You have the ultrasound set up. Everything is open sterilely. And then when you do, you're prepping all the things that you need ahead of time. So part of that is once you're all gowned up, you're flushing all the ports on the central line itself, making sure that you have the supplies lined up in the order that you need them. When we talk about a central line, I'm going to go over this kind of ad lib because I think you could read the steps on your own. For a IJ, the patient should be in Trendelenburg position, meaning there should be head down. The purpose of that is to now increase your venous congestion centrally so that your internal jugular vein is as dilated as possible and as safe as possible when you do that line. Your subclavian line, the patient should be positioned in the supine position with their arm. Usually you're doing this on the right side, hold and retracted inferiorly, and that really helps to open that clavicular, the intraclavicular space, which is right here. Femoral lines, the patient is just supine. That's pretty much your sticking in the groin. Obviously, the general steps are you prep the patient, you drape the patient, you have your kit, everything already set up and open. You will do a needle stick into the vein under ultrasound guidance. That's the standard of care now. And you're aspirating the entire time. You're sort of sticking the needle into the vein itself. Once you have dark drawback of blood, venous blood, you are then putting in the guide wire. And the entire time you're doing the procedure, you want to make sure that the guide wire isn't being lost. You're going to make a small skin. You're going to make a small skin incision that'll be for you to be able to pass the catheter through the skin. And again, you want to make sure your eyes are on the wire at all times because if you lose that in the patient, then they have to undergo additional procedures for wire retrieval. Once you have that skin nick made, you are now dilating that hole because your catheter is not the size of that guide wire. That guide wire is very small. That guide wire is very, very thin. So that's what there's dilator comes into place. You dilate, and once you dilate, you pull that dilator out through the guide wire. The guide wire is the only thing that's staying in the patient the entire time throughout this process. You're putting pressure over where that incision is because now you've made a big hole in the vein. There's going to be a lot of back bleeding. Then you put your catheter through the guide wire. And then once you see the guide wire and you have a hold of it, then you're removing that because now you've placed this catheter in place of the guide wire. That's called the Seldinger technique. Hopefully everybody's kind of seen us put a central line in. So that's kind of the general steps. This is kind of the length that you should be advancing your triple lumen catheters and the location. The biggest sort of complication, or not biggest complication, but one of the complications that you can have when placing a right subclavian or an IJ is ectopy, so arrhythmias on the monitor, and that's if your catheter is now floating within the right atrium or the right ventricle, excuse me, and you're irritating the sinoatrial node. So you always want to be watching the monitor as you're advancing the catheter. But 15 centimeters if it's a right IJ, 18 centimeters a left IJ because you have this angle kind of coming down where the clavicle is. Subclavians are about 14 because you're closer. This is just femoral anatomy. And again, this is important to know. This is basics, but this is also what we're thinking about. The internal jugular vein is more lateral than the carotid artery, but a femoral vein is more medial than the femoral artery, right? So that's kind of inverse. Does that make sense to everybody, hopefully? Just some important things to know. Arterial lines are something also we place. This is placed in an artery. Primarily, it's going to be the radial artery. People are mostly ulnar artery dominant, meaning they get most of their palmar arch perfused by their ulnar artery. This is for real-time blood pressure monitoring. So in the ICU setting, you'll see people with A lines and you'll see that red monitor, and that's what we're monitoring is their blood pressure from a second to second basis. You can also draw labs very frequently from this. Labs from the artery. This is also something that we use a lot of, and these are all things that you will be placing, you know, as a resident, and no matter what specialty, I think, for when you're in the ICU learning pretty quickly. Chest tubes, I'm not going to go over this too much. I think you all can read up on this, but I think Dustin went over kind of how we place a chest tube, the pleurovac. So these are slides in here for your review. But very quickly, this is a pleurovac. This is the biggest thing that you all need to know and have knowledge about, regardless of what service you're on. This is what determines the suction sort of strength on the actual chest tube, not the wall suction. The wall suction should always be a continuous suction. This accordion shows you whether or not the actual tube is to suction. So if the accordion is up, meaning it looks like this, there's suction to the tube. If it's completely collapsed, there's no suction on that tube. This is the water chamber or the water seal chamber. So if the patient does have an air leak, they're not sucking air back into their chest, causing a tension pneumothorax. So this is really important. And then this is just the reservoir to show you how much the outlet has been. These are kind of what's in a chest tube tray. And then this is like very step-by-step with picture instructions on how to place a chest tube. So I think if you're interested, just kind of read on your own, but these slides are in your shared guide. Okay. Fast and trauma, very, very specific indications. I think we are a less fast heavy hospital. Again, the indications for fast are unstable blunt traumas, not very much for penetrating trauma. Penetrating traumas are treated a little bit differently. If you have the experience, because fast, just like all ultrasound, is very operator dependent and your institution is very comfortable doing very quick fast, then I think it's a very good utility and adjunct of an exam to do at bedside. But the reason we're doing fast is because we're looking for free fluid in 4 different areas or 4 different quadrants, if you will, of the body. The first quadrant here that they're mentioning is in the right upper quadrant, which is Morrison's pouch. You're looking at the hepatic renal sort of junction here, and you're looking for free fluid. They're saying that you can see the diaphragm. I will say even the most experienced ultrasound technicians, that's going to be very hard, obscure to you. You're looking for gross fluid, which is going to look black in the ultrasound field between the liver and the kidney. Number 2 is your cardiac window. You're looking for fluid within the pericardium. So you're looking for seeing if there's tamponade or if there's a sort of other signs of a potential cardiac injury that you need to take the patient to the OR for. And again, that's looking for a black border between the heart and the pericardium. The third view that they're mentioning here is in the left upper quadrant. That's the splenorenal sort of junction. Again, looking for free fluid. And then the pouch of Douglas, or sort of looking at the bladder itself here, you're looking for free fluid within the pelvis. So these are the 4 views of FAST that, again, we're using primarily for unstable blunt trauma. I know Dustin talked a lot about all that and kind of everything that we do. I think my talk is going to be based upon, I think a lot of the students that are on the trauma service think that, all trauma is super exciting, penetrating surgery, but I don't think that there's very much longitudinal follow through. So, you see a patient in the trauma bay, we take them to the operating room, we're doing a clamshell thoracotomy and XLAP. What do we do with this patient afterwards, right? I think that's the biggest question, is how do we take care of these patients? And a big part of that is evidence-based and very good ICU level of care, so intensive care. And I think that is why trauma surgeons, all trauma surgeons in the country have to be critical care board certified, is because these patients are very sick usually. And with trauma, if there are polytraumas and multiple different compartments of injury, you really want to be able to take care of that patient holistically and not have to do a lot of farming out, especially because a lot of the management is primarily operating. Okay. When we are in the ICU, we take care of our patients, we present our patients, we think about our patients in a system-based manner. Meaning if any of you have done an ICU rotation here, we're talking about the patient from neuro, cardiovascular, pulmonary, GI, GU, heme, ID, musculoskeletal, and kind of in an overall, like, very compartmentalized way so that we're not really missing anything. I think for the purposes of this talk, because I think this is quite a few different topics, I think the 3 most robust topics that I think you all can benefit from more knowledge in is neuro, cardiovascular, and pulmonary. And there's a lot of obviously related topics that we'll touch base upon, I think, that are good for your education, like acid-based arrangements, antibiotics, sepsis, seizure treatment, and how we manage that. And I think that's primarily what our trauma patients are. So feel free to chime in if anybody has any questions also. For neuro, I'm going to briefly talk about kind of what drips we have for pain control and for sedation, how we manage anxiolytics in the ICU. So how do we get somebody who's super anxious on a ventilator, who has a brain bleed, to be more calm so that we can kind of get their next step in management be more appropriate. Brain bleeds and how we manage those, because we see a lot of them here as well, not just penetrating, but also for blunt. And then seizure management, because I think that's just a good knowledge base to have as a student going into any type of specialty. I think we call neurology a lot and we get very frustrated because I think neuro and derm are things that we're not very comfortable with just in general. So I think those are really good topics. For drips and for sedation, the primarily two biggest medications we use is propofol or Versed. Propofol is usually very well tolerated, but it can cause hypotension. So I think that's one of the main reasons why we would maybe back off of propofol and use more Versed. Propofol, if you titrate it down, it's very quick onset and quick offset. So if you turn the drip on and they need a lot of medication, you can turn it up to a really high dose. But let's say you want to take off their sedation and see if they're moving their extremities or see what's going on with the patient, you turn it off, and within 30 minutes to an hour, it's metabolized, and we can very much get a better understanding about the patient's neurological status. Versed can stick around a lot. It is fat soluble. So especially for older patients, if you have a very high dose drip and you have it on for a very long period of time, some patients I've seen, like a very elderly patient, take about a week, week and a half, even if we turn it completely off, to start having some level of neurological function again and be able to interact with us and have a real exam. So I think those are things that you all have to kind of think about. Cresidex is a very kind of nice drip as well. This is sedative, but it has almost little to no respiratory depression. So we use Cresidex for patients that we think we're going to be able to extubate or take off of the ventilator within 24 to 48 hours. Certainly, we still do use Cresidex for a long term, but at our hospital, because it is a little bit more on the expensive side, we tend to use it more specifically for the purposes of leaning toward extubation. Again, it does allow for some level of sedation without respiratory depression. Okay, so that's a kind of a reason why we use Cresidex. It's called dexmedetomidine, so it's kind of, people always have trouble saying that, but that's what it's called. Fentanyl, it is slightly sedated, but it is more for pain control. Used with caution, obviously. I think very high doses, when you start coming down on that, the patient's opioid receptors start getting very, very desensitized, so then they become very addicted to a lot of narcotics and things like that. So it is a drip that we use, and it is the most kind of common drip that we use that you'll see in the NICU as well as the SICU. But do realize that it is titratable, and when preferred or when possible, it is preferred that we use pushes of fentanyl as opposed to like a whole continuous drip. Those are ketamine, which is really great. I think we use a lot of ketamine in the SICU for younger patients that do have a lot of polysubstance abuse. You can use a low dose of ketamine for pain control. That is recommended by the American College of Surgeons as well. And at a low dose, you don't have the dissociative symptoms, what people call getting into a K-hole. So when people have high doses of ketamine, they are like really combative and they start having hallucinations and they're like kind of psychotic. Low doses, meaning a 0.1 to 0.2 milligrams per kilogram dose in the postoperative period, or even as an adjunct for pain, can help you kind of get their pain in better control with a decrease of sort of opioids. So decreasing your fentanyl drip was also kind of reducing why we use it. But these are the main drips to be familiar with in our unit. So questions about any of the drips, and hopefully everybody's seen them. Propofol is also what anesthesia uses for reaction. This is just a chart for everybody's better understanding of how we can control pain in a postoperative patient, SICU or not SICU, without having to use opioids, right? So Precedex is also kind of pain sort of control, and it's a continuous sort of drip. Clonidine, we usually use this in the withdrawal sort of symptom management for patients in polysubstance abuse. But clonidine can help with some pain control as well. Gabapentin and the pregabalin. So gabapentin we like to use on the general surgery services. We usually, if we can, start gabapentin 300 TID as a multimodal pain control kind of method. Gabapentin is really great. It does cause sort of a little bit of neurological depression, so sleepiness. So in the elderly, you have to be very careful. And also it's renally clear. So in patients with end-stage renal disease, you have to decrease the dose and kind of think about how much you're giving them, because that can build up. Ketamine we talked about, low dose infusion, 0.1 to 0.2 milligrams per kilogram per hour. That is great, and it doesn't have, like I said, the dissociative symptoms. Lidocaine as either an infusion, or if you're doing like regional anesthesia, so like tap blocks or other types of blocks that anesthesia can do, great adjunct for pain control that doesn't involve opioids. Tylenol is amazing. PO Tylenol is great. IV Tylenol I love, but we always say it's really expensive, but to put that in perspective, like PO Tylenol is a couple of cents. IV Tylenol is maybe like, I know some places charge like a nickel up to like 30 cents, but the patient's obviously being charged more. So when we say it's expensive, it's obviously relative, right? So it's like 30 times the cost of PO Tylenol, but it's like 30 cents a dose. So is it that expensive? Probably not. But IV Tylenol is really great that you can schedule as well. NSAIDs, these are used in much caution, especially in the ICU setting and in the post-operative patient setting. I think Toradol or Ketorolac is great, but there are some papers that will endorse sort of increased in GI bleeds. If you look at the more recent studies, I think that percentage is exceedingly low, but I think because of our experience with that and kind of our, how do I say it, kind of our historic kind of like uncomfortableness with that with GI bleeds, we kind of use it with more caution than I think we should. We don't really give ibuprofen and other things in the sort of acute setting, primarily because it can cause renal dysfunction. So, but these are kind of a lot of different adjuncts to opioids for pain control patients. And I think these are things that I hope you all think about in the future because of the whole opioid epidemic, but also when you think about and look at your patient, what you can do, like lidocaine patches or, IV Tylenol, I mean, all these things can help the patient a lot more than just keep giving them opioids. Anxiolytics, so how do we calm a patient in the ICU? Because, they wake up after days, what to them seems like seconds, and they have a breathing tube in their mouth, and they have a bunch of drains and a bunch of people, talking to them, and they don't know anything that's going on. We do give people medications for that. These are sort of the atypical and typical antipsychotics that we will start. Seroquel is kind of the one that I think more commonly used in the ICU. It is a pill, so you either have to give it through a feeding tube or rectally, something like that. Biggest things to know for Seroquel is that they can prolong QTC, so you have to get an EKG, especially in elderly patients, especially if they're on antibiotics that can also prolong QTCs. You have to be very judicious in your use of that. But Seroquel is in doses of 50, so you start with 50 and you do BID, and you can titrate up to about, I think it's 150 and 200, but the higher doses, the higher the risk of QTC prolongation. So be very careful with that. Zyprexa is something we also use. Valproic acid is an anti-seizure medication, but it is an IV infusion that you can also use for kind of a low dose sort of anti-anxiety medication. These are kind of the higher, lower risk QTC prolongation limits, but I think have these in your back pocket as well. This is just a chart for your enjoyed reading for medications that you can use for anti-anxiety in the ICU setting, but also on the floor, right? So these are not just patients that we would see. Brain bleeds. We're going to take a pause here because I know there's a lot of information. But brain bleeds are something that we see a lot of in our ICU. It is penetrating brain bleeds. So if somebody gets shot in the head and have a big subdural or some, epidural hematoma or parental bleed. It's old person on blood thinners that falls. It's a really bad MBC or car accident. Brain bleeds are going to be, I think, a type of patient population that you will see in a medicine service, a anesthesia service, a surgical service on trauma. It's just becoming more and more prevalent because of how much blood thinners we're putting on patient population or anybody. The biggest points if you're managing a patient with brain bleed that you have to know is you have to avoid hypoxia and hypotension. So if there's one thing that you'll ever do for these patients that you see that you remember from the slide, is that you should make sure that they're not desatting. So they're not on the pulse ox, they're SpO2. So saturation peripheral SP like O2 is not like, low. They should be not hypoxic and they should not have hypotension. And the biggest things because of that is you want perfusion to the brain and you want oxygen to the brain, right? So those just like basics. The way that we monitor, this is cerebral perfusion pressure, CPP, is that we take a map, so that's from a blood pressure, and we subtract it from the ICP, so the intracranial pressure. The only way that we'd be able to get an intracranial pressure is if they had an ICP monitor, right? So that's a probe that's drilled from the outside of the head into the brain, and there's a catheter floating in there, taking pressures of the brain. Or the patient has what's called an extraventricular drain, and that is a drain that is surgically placed by neurosurgery that also drains fluid or something inside the calvarium, and it also monitors the pressure. So the only way that we'd be able to get a cerebral perfusion pressure is if they had some type of invasive monitor. Certainly, if we are placing an ICP monitor, it's because we're afraid that we are compromising the cerebral perfusion pressure because of some mass occupying lesion, right? So some brain bleed or something that's causing them to have less space. Because as more space is being occupied within the brain, pressures increase, which means that you have to have a higher blood pressure to pump or perfuse the brain. Hopefully that makes sense. Basic principles of physiology. Let's say you have a patient and all of a sudden they have an acute spike of their intracranial pressure. So this is like a trauma patient that had a gunshot wound to the head, a brain bleed that was stable, but all of a sudden they have a huge change in their neurological status. And we're really concerned that now the brain bleed has got a lot worse. How do we kind of temporize this patient before neurosurgery can get into the hospital? How do we temporize the patient so that we can get them to the CT scanner? There's a couple of things that we can do. We can hyperventilate the patient. That number one increases your oxygen saturation in the brain, obviously number one, but it also decreases your CO2 levels, which causes sort of vasoconstriction. We don't want to hyperventilate the patient long term, but in a short period of time, it does help to acutely decrease the intracranial pressure. So hyperventilating, meaning make them breathe faster, breathe off the CO2 and sort of like hyperventilate them, right? Elevate the head of the bed. I know that's silly to think about, but gravity is the strongest force in the universe. So elevate their head and hyperventilate them. These two things alone can do so much for the patient to make sure that they don't herniate or push the brainstem so far down the sort of thoracic inlet that you're now causing them to be sort of brain dead. The other adjuncts are mannitol and hypertonic saline. So hopefully you all have seen kind of in the ED bay or in the SICU, we are talking about giving patients one of these two, and usually it's hypertonic saline, which is 3% saline. Normal saline, which is 0.9% saline, is it's 157 milliequivalents of sodium and chloride. 3% is like 3 times that. So it's super hypertonic saline, it's hyperosmotic. It's causing you to have shift up your extracellular, interstitial fluid and volume intravascularly so that you're decreasing tissue swelling. Does that make sense? Hopefully. So you're trying to increase your intravascular colloid or pressure so that that gradient is shifting fluid from the tissues into the actual intravascular space. Hypertonic saline is a great volume expander, like I said, so intravascular volume. Mannitol is an osmotic diuretic, so it causes shift of fluids, but it's osmotically active. You have to be very careful of this in renal patients because that can cause a lot of renal dysfunction as well. I think if you look at the current studies, hypertonic saline has had better success at decreasing intracranial pressure in sort of a longer term management. So I think the more preferred hypertonic saline, but the studies go back and forth. So it's not like one is overtly better than the other. I think they're both, just depending on the trend of the year, is going to be used one or the other. But that's kind of the basics of a brain bleed protection. So hopefully that's like, yeah.
So what do you give for the alkalosis cell causing the hyperventilation?
We don't. So we'll talk about acid-based arrangements, but respiratory compensation for alkalosis and acidosis is very quick onset and quick offset. So if we don't need to hyperventilate and we stop, the alkalosis will cease to exist because your respiratory status and your compensation is much quicker to adapt than your metabolic adaptation, which is bicarb. And the way that we would manage that is with sort of renal excretion or absorption of bicarb. But we'll get into that with the acid.
Give a brief idea of like what happens when all of this doesn't work.
Yeah, if this doesn't work and the patient's brain bleed is getting worse, it is a emergent call to neurosurgery, even as all this is happening. And they have to do a craniectomy. So they take out a portion of your skull. That portion of your skull is usually saved and put into a flap in your belly, like outside of the peritoneal cavity, but in the subcutaneous tissue, so the fat, like underneath the skin. And you're evacuating and creating an area for that pressure to decompress. So it's a craniectomy. And then they'll do cranioplasty, which is once the patient's all recovered, we have to put the skull back on, but that's much later in the course of the patient's sort of hospice stay. But if a patient's having increased intracranial pressures, the bleed is getting worse, neurosurgery needs to come and decompress them because there's nowhere else for that pressure or that blood or that space occupying lesion to go. We have to create space for them. Seizure management, I think, what comes with brain bleeds is seizures, obviously. And also just seizures in general, like let's say for, alcohol withdrawal, delirium tremens, things like that. Seizure management, usually I think it's a very good practice that if you have patients with seizures, you have to get an EEG, you have to see kind of their epileptic form and neurology when you consult them for new onset seizures, because, you may treat them acutely, but you're not gonna follow them for life. You're not gonna follow them as an outpatient. You're not gonna manage their dosing and the medications. You should be placing a neurology consult, and part of that is they're gonna want an EEG. Maintenance, meaning, and even just sort of acute treatment, and prevention of seizures, you could use Dilantin or phenytoin or Keppra. Keppra is usually kind of what hopefully everybody's kind of familiar with in terms of a name. Keppra is pretty innocuous, meaning you can give it, and it's not really harmful to the patient, which is a great thing. Couple of issues though, you can keep giving Keppra like in very increasing doses, but if you give it IV because the patient can't tolerate anything PO, it is a large volume of fluid. And for brain bleed patients, we're trying to restrict fluids or keep them net negative, because more volume of fluid means more chances and more likelihood that they're going to swell. And if they have edema of brain tissue, then that worsens their brain bleed and their brain sort of space and pressure, right? So Keppra is a really great medication, but if you're giving it IV, it can be quite large volumes. PO is great. Usually the benefit of Keppra for seizure prophylaxis, meaning they have not had seizures yet, but in a trauma setting, they have a brain bleed, is 7 days. So oftentimes, we call neurosurgeon, you'll see patients on Keppra, but that's for prophylaxis, meaning they haven't had a seizure yet. If they have seizures, then they'll need to be on a medication, depending on the inciting event and stuff for a longer period of time. But Kepra's benefit for prophylaxis, or prevention of seizures, is 7 days. Acute treatment, meaning a patient is seizing right in front of me. What do I do? You have to give the medications to break the seizure. Usually that comes in the form of a benzo. So Ativan is great. Versed, we have used a lot here now because Ativan have had a shortage for a while. Ativan is just shorter acting, Versed is longer acting, so that's kind of the difference. But Ativan or Versed or diazepam, so a type of benzo, and that will help to lower, or I guess increase your seizure threshold. I guess if you, either way you look at it, it'll help for your membrane potential to be at a lot higher threshold, so that the patients aren't seizing as easily, if that makes sense. So like the sodium, potassium and stuff, but anyway. Other adjuncts that you can use, phenobarbital is really great. That is usually a loading dose. It's 10 kilograms, 10 milligrams per kilogram, one-time dose. And then there are 2 subsequent doses if you want to give it. And then lacosamide. Lacosamide is a very expensive drug, but it is also very great for seizures. We'll use it if somebody is in status epilepticus. So you're giving them a lot of medication. They're still having quite a bit of seizure activity, or you think that they may have sort of low sort of basal level of epileptic form sort of seizure activity, you can give all these medications. This is the American Epilepsy Society sort of step-up approach to seizure treatment. It starts with EEG monitoring, ECG, also EKG monitoring, but also different levels of medication that you can give, and what if they continue to seize. Again, this is a lot to go over, and this is just for you as a resource to look back on. So again, the slides are on the shared drive.
Just quickly.
Of course, before we move on.
Thank you. Can you tell them what you see hemodynamically when someone is herniating?
Yeah, so you have something called the Cushing effect as well. So if they are herniating, it's this kind of weird bradycardia with blood pressure derangements. And and some level of respiratory, not really Kussmaul breathing, but if a patient is herniating, you will see a couple things. And number one is, if it's a really bad herniation, you'll see posturing. And that's kind of on our GCS score as well. So hopefully everybody, we can review GCS, but Dustin, I think kind of went over that. But part of your motor, which is out of how many points? So what are the components of a GCS? Okay, eye, verbal motor, and what is the minimum score we can have for a GCS? 3, right? So even if you're dead, you have a score of 3. That's 1, 1, 1. What is the maximum score we can have for a GCS? 15, right? And always think about it's 4, 5, 6, 4, 5, 6. Eyeballs, verbal, motor. Your motor is at a 6 points, right? 6, like if you have a GCS and your motor score is 6, that's like a normal person, you know, look like normal spontaneous movement. 1 is no movement at all, right? So I always think that I like to think of the extremes because I think those are easiest to remember. But then you work your way kind of from one to the other. 5 is you localize to pain, right? So you like somebody pinches you, you're like, ow, that hurts. 4 is if you react to pain, but you can't localize. So you pinch somebody or somebody's in the EDBA and you're like pinching their toes or their nail beds and they kind of like they're reacting, but they are not like localizing meaning somewhere like to pain. 3 is decerebrate positioning or posturing. So that's arms are kind of out this way with sort of, what is this, extension. And then it's decorticate. So you're protecting your core. That's how I learned it. That's worse, right? Because you're like, oh, things are so bad. Those are kind of herniation signs or kind of precursors to that. And then 1, like I said, is you can't move at all. But vital signs you will see it's a Cushing's effect, and you will see posturing as well. But usually if they're like having Cushing and it's a little bit too late for them because I feel like that at that point they're already partially herniated, or even if you get them emergently into the operating room, the chances of them having meaningful recoveries.
I wanted to add, it's just like
Very
sometimes it's just a very subtle human changes the bradycardia in particular, right?
Yeah.
You have a son. So they may seem okay, or maybe your ICP peaks for a little bit, but then comes that, you know, it seems like it's responding appropriately to your measures. But then you start seeing like just a little brief episode of bradycardia, but then it recovers. I mean, sometimes those are like initial signs that, you know, like if you're covering the unit and you're getting a call, like little subtleties like that are things that are important to like escalate.
Yeah, and it's like I said, it's 3 things, right? So it's your bradycardic, so you're low heart rate. You're hypertensive, so your blood pressure is deranged, and that it's kind of weird. And then your respirations are really deep. It's with pushing stress. And then call for help.
Yeah.
That's the punchline is call for help. So, okay, are we ready for cardiovascular? This is going much quicker than I anticipated. Zooming through things because
You can start asking more questions.
Yeah. I think we're gonna do we'll ask more questions when it comes to cardiovascular. On cardiovascular also. I think neuro is like no one's comfortable with, but you all should know about the heart and lungs, right? So we're gonna talk about hypotension, what massive transfusion protocol is, and what we do during massive transfusion protocol that has been evidence-based and shown for decrease in mortality. So what increases their chances of survival. Hypertension, how we manage that, and set of arrhythmias. So when we are assessing somebody in the setting of hypotension, especially in the ICU or even at bedside on the floor, I think there's a lot of things that we can do just at the bedside and sort of just with clinical information that can give us a good understanding of the patient's fluid status. The easiest thing is a straight leg raise. You put the patient supine and you literally lift up their legs. And what that is doing is you're shifting their intravascular volume from their lower extremities centrally. That's as effective as giving like a 500 ml bolus in a patient. And what you're looking for is if the patient is hypotensive and you do a straight leg raise, you are looking for a change in their systolic blood pressure anywhere from about 10 to 20 millimoles per mercury. So blood pressure systolic is changing. Let's say they're at like 90 and you do a straight leg raise, it all goes up to 110 or 120. They need some volume, their volume down, right? So this is a quick assessment of a patient. Do they need some volume? You can do, if you are in the ICU and you have an ultrasound, you can look at their IVC, so their inferior vena cava. How collapsible is it? That is a very good assessment of their fluid status, right? Your IVC is looking at your preload, your body's sort of volume that's returning to the heart, right? Your preload. If there's not a lot of volume coming to your heart and they're hypotensive and tachycardic, they probably need some volume, right? And you're looking to see what the size is and kind of the collapsibility. That's a little bit more technical, and you have to know how to look for the IVC and what you're looking for ultrasound. But the straight leg raise anybody can do, right? Like 2 people lift up the legs. That's easy. Urine output. I cannot stress this enough. There's a reason why on rounds in the morning we ask you if somebody has a Foley, what their urine output was, right? And we don't want 12 hours. 12 hours is great, but we want a 24-hour urine output. Why is that? That is a surrogate marker for kidney perfusion. And if you're looking at one organ that's like high volume being perfused, it's your kidneys, right? Like your brain too, but what are you gonna do for your brain that's monitoring your bedside? You can't, right? So urine output is a very good surrogate marker at looking to see whether or not your blood pressure is good or if the patient is perfusing. What is, Tony, you're not gonna pay for me. What is adequate urine output in a patient? Okay. I'll open up this to the room. She wants-
Say six,
Anybody?
eight
68 what?
liters.
Liter, so a baby could make 68 liters, that's
No,
normal.
not-
Right, so like everything in medicine,
Yeah.
it is a weight-based normal.
Per
So,
kilogram.
so 5 is a lot, so 0.5, yeah, to 1 milliliter per kilogram per hour, right? So we say anywhere from like 30 to 40 mLs per hour, because we're thinking about a 70 kilogram average person. That times 0.5, so that's dividing it by 2 is 35. That'd be 35 mLs per hour of urine output. That would be adequate. So 0.5 to 1 milliliters per kilogram per hour is adequate urine output. So we ask these things because if they're not making enough urine, do they need fluids, especially after surgery where we have a lot of shifts of fluid, right? Especially with like intractable losses, like we do a big X-lap, and a lot of fluid is being lost from the body. So urine output is great. Central venous pressure, I think this is a provider sort of style. A central venous pressure is looking at your central pressure in your veins. It's like, I don't know how else to say it, the name kind of says it all. This is an invasive type of monitoring. It does require a central line in the IJ or the subclavian. Not a femoral. The femoral is too far from the heart. It has to be a very central, actually located line. Normal central venous pressure is anywhere from 8 to 12. So, you know, if it's high or if it's low, that can give you some clue for your blood pressure. But they did do a study, like this was quite a few years ago, I think it's like 15, 20 years ago, where they took a bunch of animals, unfortunately, because we're not going to do this to humans, and we did varying levels of blood loss, and we looked at central venous pressure. And there was not a clear trend. So 500 versus a liter of blood loss versus 2 liters of blood loss, all of those central venous pressures were all over the place. And so whether or not the true utility of a central venous pressure is a good surrogate marker left to be determined from evidence-based medicine. So some providers really love it. Dr. Chang loves it. Some people do not. I think there is some utility given no other sort of knowledge to it, but it is kind of hit or miss. So just as a piece of.
So generally speaking, when should they start thinking about CBT? Like putting, you know,
I think that
or you're saying it's just.
for central venous pressure, if that is your use of addressing the pressure, I think that's attending dependent. If you are thinking about putting a central line in, I think that's a separate question. But adjuncts of blood pressure sort of evaluation, we're going to go into a couple other ones. I think that one is more attending dependent. If you're thinking about putting in a central line, there are very specific reasons why we put in central lines. It is not because we cannot get IV access. Sometimes it is, but that's a very extreme situation. But we are placing central access because we need to give medications that we cannot give through an IV. That is things like pressors. That is things like hypertonic saline for 3% for brain weight. That is things like TPN. So if the patient needs nutrition through the IV, if the patient needs a lot of support because they're so hypotensive that they can't maintain perfusion and we need to start pressors, we would put an IJ in regardless, or a femoral or some type of central line. The central venous pressure is kind of like a nice bonus, but I will say most of our attendings and all the other ICs that I've been at, so Northwestern, Loyola, Harvard, UCLA proper, most of their attendings would not use a central venous pressure. I just think it's a hit or miss depending on the attendance training. This is another very invasive adjunct, but this gives you the most information that you possibly could ever want for blood pressure monitoring. And it will give you more information and help you to delineate the etiology or the cause of your hypertension. So this is called a Swan-Ganz catheter, or it's a pulmonary artery catheter, pulmonary artery line. So this is a catheter that is in sort of the pulmonary artery, as it would suggest, looking at the pressures in all of your in the pulmonary artery, and it is a surrogate marker for your left atrial pressure. And what it gives you is a lot of different information. It gives you cardiac index, it gives you a PA systolic and a mean pressure. And it gives you a way to determine what is causing this patient to be hypotensive. Is it coming from the heart? Is it coming because they have no volume? Is it becoming because they are like neurogenically, like in neurogenic shock? It gives you the most information, but it is the most invasive type of monitoring. Patients in the ICU in the past would all get this, but this is the very old school way of determining causes of blood pressure monitoring because it is so invasive. Cardiac surgery patients will always get this, will still be getting this because you're monitoring the cardiac index. You're monitoring their cardiogenic shock and when it is safe to come off of pressor. So that is a very different situation, but either way, this is when you are actually putting in the line. This is something hopefully you all have seen on step 2 probably, right? Like what are the waveforms and the pressures in the right atrium and the right ventricle and the left atrium and the left ventricle. And if you were to put like a line in there, what would you look at? So the right atrium is here. The systolic pressure is low, because this is just a preload, right? You're anywhere from 0 to 5. So it's a very low flow state. This is just like blood returning to your right atrium. Your right ventricle is going to have some back pressure because you're now finding your tricuspid valve, right? Because you're now trying to get blood into your lungs. So you have back pressure. So the pressure of this is quite high. Also, if you think about the musculature of the heart, your right atrium has minimal musculature. The right ventricle and the left ventricle have much more sort of musculature because it has to pump against a closed glottis, a valve, to push blood forward into your circulatory system. So you have to generate more pressure in your right ventricle. So that's why your pressure should be higher, right? Your PA is right here. And then this is your dichotic notch to kind of know where you are. This is the back pressure that you're getting from the right ventricle. This is kind of where when you know that you are in the correct space. This step off is meaning that your now mean pressure in the right pulmonary, like in the pulmonary artery, excuse me, is at a much higher, less differential. Like in the right ventricle, there's emptying and filling phase, right? You go from high pressures to low pressures, from high pressures to low pressures. So that's what this is showing right here. In your PA, your pulmonary artery, your pressures are much more contracting. They're going to be at a higher baseline because you're already in a very closed system, which is your lung. So this is just for your knowledge. This is some adjuncts on like your pulmonary artery catheter. So it measures a lot of different things like your diastolic pressure, your wedge pressure, your pulmonary artery wedge pressure, which is kind of like a surrogate marker for your left atrium, your left atrial pressure. Indications for this is if they have pulmonary hypertension, but I would say this is less done now. Shock, less done. Cardiogenic shock, potentially. MI, you would be floating different types of catheters, like a balloon pump that's out of the scope of this talk. Systolic heart failure, severe chronic heart failure, where you kind of need to know what's going on a time by time basis. Contraindications, you wouldn't put this big catheter in the heart and in the pulmonary artery if they had like coagulopathy, so they bled a bunch, unless you absolutely had to know a pacemaker, because you could make that pacemaker malfunction. Infection, because this is another infection risk, right? Or if they had a big mass in the heart, they're going to perforate and cause more issues. But this is how this is how the line goes. It goes through your superior vena cava, through your right atrium, through your right ventricle, past your tricuspid valve, and into your pulmonary artery. So it's a very invasive type of monitoring, right? So we don't do this very.
At the tip there's a balloon.
Yeah, there's a balloon that you blow up to get your pressure. So that's like how you're getting your actual pressure. So it's like you could rupture. It's a lot of problems. It's just that we don't do this anymore. Yeah, we don't do this anymore.
But can you just quickly cover those complications real quick? I mean,
Oh, yeah,
even though they're extraordinarily rare, they are extra.
Yeah.
Easy.
So thrombosis. So what if you clot up one of these arteries? Because you now have like turbulent flow, right? So we always think about laminar flow. That's what we have in our blood vessels. Turbulent flow is like there's somewhere that's causing the flow to be so out of whack that it's going to be embologenic or thrombogenic, excuse me. You're going to be able to cause a blood clot. If you cause a blood clot in any of these blood vessels, that's a big problem, especially if you're not getting PEs, pulmonary line, right? Bruising, hematoma, that's just bleeding from the line itself. Infection, like I said, is a big thing, because now you're taking somebody who didn't have an infection risk maybe and putting bacteria or sources of infection directly into the heart and into the vasculature of the lungs. That's a huge problem. Bleeding, you're putting a cap anywhere, there's bleeding everywhere, so that's bad. pneumothorax or hemothorax, you potentially could perforate one of these blood vessels, or as you're putting it, this is usually kept to a subclavian line. You could cause a pneumothorax bleeding into the chest. Cardiac arrhythmias, we talked about when you're placing an IJ catheter, you can see ectopy. Well, this is sitting there forever, like not forever, but it's sitting there constantly as you're monitoring it. So that can cause arrhythmias that could be potentially life-threatening. Tamponade, so if you perforate the right atrium or something, you can cause them to tamponade. And then pulmonary infarction, if you cause emboli, like, and you're occluding blood flow, or a PA rupture, that's like life-threatening, honestly. This blood vessel has burst open now and you're having massive hemorrhage. That's a sternotomy and a repair, so super dangerous. Why do we do it though? Why did we used to always do this? Is because it would tell you all these parameters. You could see heart rate obviously from that. You can calculate your cardiac output, which is your stroke volume times your heart rate, right? Your central venous pressure you can get from that. You get your pulmonary capillary wedge pressure, which is that surrogate marker for your left atrium. Systemic vascular resistance, which you'd also be able to get, and your O2 saturation, which is kind of like your ongoing monitoring too, right? You would be able to determine whether or not this is cardiogenic, neurogenic, septic shock, hypovolemic shock, or anaphylactic shock, depending on these parameters. And this is something that we're frequently tested on. I don't know if you all are. I know there was maybe a short table in step 2 or like USMLE step 1, where it's like your cardiac output has now decreased, but your heart rate is this, and what type of, this is most consistent with this type of shock, right? So still useful nowadays, we still have to know it, but like this kind of makes sense, right? Septic shock is a type of shock that is distributed, meaning you have massive vasodilation because of a cytokine release, right? So your cardiac output is going to increase because you're trying to pump as much as you can to perfuse everything. Your heart rate is high because you're trying to perfuse everything, right? Your cardiac output is high. Your heart is trying to work as hard as it can to perfuse all of your distal end organs and your tissue. Central venous pressure can be elevated if everything is clamped down, or it could just be normal. Your this is kind of like your afterload, if you will, right? Your left atrial pressure. It's low because again, it's distributed. All of your vessels are dilated, right? And then your systemic vascular resistance, like we talked about already, it's going to be low because everything is vasodilated, as opposed to like cardiogenic shock. Your cardiac output is going to be really low because your heart isn't working, so it's not pumping really well, right? Your heart rate may be up and it's trying to work as hard as it can to pump, but it's not functioning very well. Your pressures and your central venous pressure is going to be about the same, if not higher. This is kind of like a wash, right? Your afterload, or all of your blood vessels, are going to be clamped down because they're trying to perfuse your heart. Your heart is pumping so hard to work on getting everything perfused. So if you think about it from a logical standpoint, so just dead memorization, you should be able to figure out what that is, right? Hypovolemic is kind of the, in a way, it's the same thing as a septic shock kind of picture, except that your veins and your peripheral vessels are able to clamp down, right? Because we don't have that massive release of cytokines preventing them from clamping down. So it's literally the kind of like the same type of shock, except for that you don't have enough blood coming back to your heart. So just kind of think of it that way. So your cardiac output would be down, but your systemic vascular resistance is high. Neurogenic is just because you've had a bad spinal cord injury and your heart is okay, but everything is so dilated because you have no sympathetic tone to your muscles, to your tissues. But for your review. Okay. I think more importantly though than this pulmonary capillary blood pressure, if you are going to see hypotension, especially in a trauma patient, general surgery patient, or any patient in the future, it's probably going to be primarily in the setting of sepsis. And I think any good physician should know how to manage sepsis and the principles of it. So this is kind of like a big, not passion of mine, but I think it's like on my high horse, which is like, as a student, as a resident, as a doctor, you have to know how to manage sepsis because it's just that prevalent, right? And obviously in cardiovascular, most patients will be hypotensive because they have some infection or they have some source of something going on that's causing them to be septic, right? In sepsis and in septic shock, there are different flavors. So sepsis is kind of this massive sort of release of cytokines like we talked about, and a sort of overall response to some level of infection. If they are responsive to fluid resuscitation, they're in sepsis. If they are not responsive to fluids, meaning they're still hypotensive, then they're in septic shock. Like, hopefully that makes sense. So kind of different verbiage, vernacular, if you will, but it's all kind of means the same thing. How do we treat sepsis and why do we treat sepsis the way that we do? It's because we've done years and years of studies, and we have done studies that have shown to be of mortality benefit. So there are guidelines, they're called the surviving sepsis guidelines. And every hospital will have a like sepsis or septic shock protocol, because it is a milestone for the hospital to see how well these patients do, because we have so much evidence showing better outcomes, good outcomes, if we treat patients a certain way and we manage them a certain way. So this is a very poignant sort of topic, which is like you as a physician, as an attending, are judged and your performance is based upon how well you treat these patients. Your patients will survive and do better if you treat them a certain way and you manage their sepsis a certain way. So it is a very big point of attention.
From the ER.
From the ER or even on the floor in the ICU, anywhere. Like
Even your doctors now.
everybody is,
It's life saving.
yeah, it is. This is like no joke.
That's why there's sepsis alerts in a lot of hospitals. To kind of get everyone mobilized to start all these.
Get your stuff together, yeah. The biggest things that you can take away from this slide or this presentation is how to treat a septic patient. And these are things that you have to do. These are like no question in the story that you have to do these. You have to initially resuscitate the patient, and it is a weight-based resuscitation. I want you to burn this number into your brain. It is a 30 cc per kg resuscitation. It's not like an elevator, but
Yeah.
I'll go down this. It is 30 cc's per kg. So we always say, like, give the patient a 2-liter bolus. Why? Right? Like, give the adult patient a 2-liter. Give the adult patient a 2-liter cc bolus, like 2-liter bolus. It's because 70 kgs times 30 is 2,100, so 2,100. If you're gonna bolus the patient, it's gonna be 2-liter bags, about like 2-liter bags plus 100, so it's a 2-liter bolus. So 30 cc's. This is 30 cc or 30 mLs per kg. Okay, that's good. You are continuing your resuscitation and you're basing your resuscitation off of lactate or a lactic acidosis. They usually, so you're trending lactates, and that is how you're gonna determine when you need to back off of your resuscitation, but you have to get a baseline lactate. You should pan culture the patient. You have to get cultures. And then you're gonna start antibiotics before you, you're gonna start antibiotics after you get cultures from the patient. So it's like a very stepwise approach, right? So give them fluids, you need to get labs, you need to lactate, you all get all this stuff, and you need to give them antibiotics. And early initiation of antibiotics is one of the things that we really have to do. And we have to give them broad spectrum. And then if they are still in refractory shock, then we start pressors. But before we get to the whole pressor and everything, what do we mean when we say that we want to give somebody broad spectrum antibiotics? Can anybody tell me what we're trying to cover? So gram negatives and gram positives. Can somebody else give me something else? Anaerobes. What else? I'm sorry. Not so much. What do you mean by atypicals? Like chlamydia? Like that's atypical. No, we're not covering that.
MRSA.
MRSA's great. Okay, what else? There's one thing else that you guys are missing that is a larger, broader thing that's very common. Starts with the M, ends with an URSA. MRSA, right? So when we talk about broad spectrum antibiotics, we're covering for a finite amount of things. It's not just like we're going to throw everything at them. Gram positives, gram negatives, aerobic, anaerobics, MRSA, and Pseudomonas. That is what broad spectrum coverage is. I think antibiotics are so important because I think a lot of people and a lot of residents will start antibiotics. Why are we doing these antibiotics? What are we covering for? Well, that's just what my senior does. So that's just what we're doing. That doesn't make any sense. Like, if you're going to practice medicine, it should be evidence-based. You should know exactly what you're trying to cover for. And I think the biggest thing for students is antibiotics. It seems to be such like a scary topic, but there's a couple things we're going to break down. And we'll need to leave in like 2 minutes. Just for that trauma, I'll be right. But the 2 things before I leave are what covers Pseudomonas and what covers MRSA. because the gram positive, gram negative and anaerobics are a little bit easier. We'll talk about that, but sit on that for a second. We're gonna make a list. I'll be back in 2 minutes. I'm just gonna see if it's emergent or not. And then
The other thing is you always want to be aware of what they're, because the ER will often start these, but you may not be like more appropriate. So you'll get a call, oh wait, already given antibiotic, yeah, so it's kind of like out of your mind, okay, that's covered. But you want to make sure that it's the appropriate antibiotic and appropriately covered, and also when transfers come in is. The other thing is, when you're dealing with cardiovascular system, let's talk about kind of like the endpoints of when your thresholds for basically escalating the issue. So like, let's say you're an intern in the unit, someone's a little hypertensive, or your output's a little low. What would be the first thing that you would start doing? Good, yeah, always say that, good. Darren, thank you. Okay,
And then maybe like.
great, okay. And so the bolus we just talked about would be about what? Okay, good. And then what's your plan? I mean, you're getting calls, you got 5 other people and then 2 new consults. Now what?
Hypotensive.
You know, 85, 90, so not like an extremist, but not so good. One time.
Maybe over some files. Did I have a fever?
No,
Again,
it depends on like kind of the clinical story of what's going on with that patient. I was thinking more of, so you give a bolus and you tell the nurse, give me a call, let me know you're in like 30 minutes in, right? Is that enough? I mean, how often do you think, unfortunately, in this day and age, where you can even get that? And if you've got to go see a couple of consults and then like go tell your senior or your attending, that's kind of off your mind. Especially if somebody's kind of equivocal, you know, the numbers are a little not so perfect, but they're not horrible. So you feel like, okay, done, I gave them that homework. But what you've got to make sure you do with those beautiful lists you make is you got to recircle back. You know, it's easy to do like now because it's on the EMR, you just do your phones, the heart rate, that kind of thing is. But you got to definitely make sure you circle back. Also thinking about like, so let's say you go back, you round back up there in like an hour, and you say like, okay, they had, you know, 150 cc's of urine, but their pressure is still like around 90, heart rate still 110. What do you think next? Anybody? I mean, I think it would depend on how sick, like we talking about ICU patients, intubated, that kind of thing. Do we want to check lactate? You know, starts giving us potentially.
they don't have a fever, so.
Okay. I feel like generally speaking, like one bolus and they've had some response, maybe second bolus, you know, if that was 500, 500. And then you want to see what the response is. You know, if they're still kind of around 80, you're an output, a little response, but not perfect, still a little tacky. What were your next thoughts? You're your intern, you're getting calls from all kinds of other stuff, given a leader now, or the person's still kind of about the same. We just do exceptions for all of them. Yeah, you might want to. Okay, and then.
Oh, no, I said I would just give
Yeah,
more clues.
like, it's always good to like regroup and go back over things, make sure you understand, like, because lots of your cross covering, right? You make sure you understand everything about this person and take some time to do that. But it may be a time to start thinking about escalating, you know, like to let your senior know. I'm gonna be given another bolus, because you think they're probably still a little dry. Seems like they had a little response, or maybe it's more fluid. Seemed like they had a little bit of a response, so that's great, but we don't want to like let our senior know too late, right? So I think that's important. And then I think as a sub-I, as a student, like if you're like tailing around with an intern, a really good thing to do that looks super good and is very important for your learning is your intern just bolus this person and they're scurrying around doing everything. You're going to go back and you're going to say, hey, it's been an hour, they seem to respond to the bolus, or I noticed that your output's still a little low. So that's kind of your responsibility. You know, we talked about like, you want to start thinking on that level. And then start, I think the second level of that is like strategy. You know, you're gonna start thinking about like, well, what would come next, you know?
Okay, hopefully we all made a list of antibiotics that cover.
Sorry.
All right, because this is all review, everybody give me one antibiotic starting. Okay. What are some things that you think cover Pseudomonas? So third and fourth generation cephalosporins too. Extended spectrum, so yeah, what else? Aminoglycosides, great, I think I heard that. Carbapenems, I heard too. Polymixes, okay, so that being is like, this should be a not difficult activity, right? We should know all those without a book. Because I think Pseudomonas coverage, MRSA coverage, those two things, I think you need to know off the top of your head. So some of this is just an antibiotic time, which should be done within an hour. Okay. Antibiotics for sepsis is broad spectrum, like we talked about, gram positive, gram negative, aerobic, anaerobic, MRSA, and Pseudomonas. This is the antibiotic ladder. So we start with like penicillin, which very rare if we use that nowadays. And if we're trying to cover for MSSA, like a oxacillin or nafcillin, ampicillin, so this is Unicin, or like Augmentin covers another layer of stuff, right? If we want MRSA coverage, we go to Vanc. If we want VRD coverage, we go to one else. So this is kind of just for gram positive and gram negative. Anaerobic coverage is usually two different types of drugs. So if it's below the diaphragm, we use Flagyl or metronidazole. That helps cover a lot of things. If it's above the diaphragm, then we're trying to use clindamycin. Things that can cover in both areas are carbapenems, and whatever, the beta-lactam is so like amoxicillin, things like that, right? But amoxicillin has some anaerobic coverage. It's nice. It's kind of like a one pill within a more compliance issue. So we're gonna go to this is MRSA now. This is MRSA first. I always make it a point to ask the students like, what PO regimens can you give for a patient? Say, let's say you're worried about a MRSA superficial like skin infection or soft tissue infection. So Clinda, Doxy, Bactrim. Linezolid technically is also PO, but it's super expensive. But as an outpatient, what can you use to cover MRSA? Clinda, Doxy, Bactrim. Clinda, Doxy, Bactrim. Burn it into your head. PO MRSA coverage. Clinda, Doxy, Bactrim. Linezolid also, but it's very expensive. IV, Vanc is very easy to give, but can cause Remington syndrome if it's infused too quickly. Vanc is also nephrotoxic, right? So kidney damage. Daptomycin, super big gun. We don't use that very often if we just need MRSA coverage. Septarly, a fifth generation cephalosporin. Fifth generation cephalosporin. We do not use really because Vanc is just way cheaper and it's just more readily available. Some of these other ones we don't even use in our hospital, it just depends on hospital formulary. But the ones you should know, like linezolid we do use, but that's mostly for VRE. That's not really just for MRSA coverage. Doxy, Clinda, Bactrim. Vanc is great. Vanc is great. Right? We're going to the slide. We're going to come into that. And then Pseudomonas. So this is the mnemonic that I was brought up with in USMLE's Step 1. So campfire, so carbapenems, so like imipenem and cisplatin, things like that, right? Aminoglycosides, that is also nephro and ototoxic. I just weird things in my brain when I took Step 1. It was like amino was nephro and ototoxic. So you have to be mindful of the renal patients. Monobactams. Monobactams, that is stuff like Zosyn. No, that is extended. This is monobactams is something different. I'm so sorry. Polymixins, polymixin B, cisplatin. We talked about this is super. You're never really going to use this unless like ID is giving you the go ahead for this. Fluoroquinolone, so Cipro, things like that. Third and fourth generation cephalosporins and extended spectrum penicillins. Commit this to memory, please. This is so important. Monobactam is estrianam. That's what it means. So estrianam can fight, but if you're gonna need pseudomonal coverage, you're just gonna start a fluoroquinolone like only on a sole basis or something else like Zosyn that is gonna go back. So to put this now in a clinical perspective, what do we use for broad spectrum antibiotics here? Right, we use the classic is always vanc dosing. So the vanc is covering as part of our talk, the gram positives. It is going to cover the aerobics. It's going to cover the MRSA, right? That's already covering like 3 things. Docin, so piperacillin tazobactam is covering your gram negatives, your anaerobics, and your pseudomonas, right? We use at this hospital because Zosyn is ID restricted. We use vanc, cepi, flagyl. Vancomycin, cefepime, flagyl, right? So vanc is again covering the gram positive and the aerobics and the MRSA. Cefepime is a 4th generation cephalosporin that's covering the gram negatives and pseudomonas. Flagyl is covering the anaerobics. Does that make sense? So there's a rhyme and reason as to why we're picking certain antibiotics. We don't just do it because of whatever reason. Why do we use Rocephin versus cefepime? I think that's a big point of question for some of y'all as well. Cefepime, if we think that we need to broaden because they have pseudomonas. Otherwise, Rocephin or ceftriaxone, 3rd generation cephalosporin, has great intra-abdominal gram negative, some gram positive coverage that is going to cover everything that we're kind of concerned with. So sometimes we have Rocephin and flagyl. That's like your gallbladder, cholecystitis, your appendicitis coverage, right? Intra-abdominal, anaerobic, gram negatives, some gram positive. That's what we're treating. And certainly, if you think about intra-abdominal sources of infection, if you have spontaneous bacterial peritonitis and SBP, right? Your first go-to treatment antibiotic-wise is a 3rd generation cephalosporin. So that is why we're using certain medications for those purposes. Okay. But this is always a good review, and I think everybody should always know this. I think another really great resource that I used when I was a med student is something called Online MedEd with that like bald doctor. I don't remember like Dr. I don't know what his name is, but like he has a really good series of like short videos and like notes, and like his antibiotic router is like super easy, and there's like a diamond for the fluoroquinolones and stuff, and it's like covering certain things, but like other research, there's a lot of research out there, but I think there's a lot that you can do to just always be reviewing antibiotics as a whole, because it's just, we just like kind of do it because like, oh, it's fine, just give this antibiotic, like, but why? Why can't we de-escalate, right? So anyway. My soapbox. Okay.
And one quick thing, just like later on, again, sub-I, intern, or just like resident things, check your cultures sensitivities often, regularly, because even at the most upper echelon of care, you'd be shocked how often a day or 2 or day and a half goes by where someone's sensitivities came back and they're resistant to something they're on and nobody knows it. So just twice a day, at the very least, you're following back up on those sensitivities and checking, making sure that they're on the appropriate meds. And then also sometimes it can come off of some of these like nephrotoxic meds that can come based on when those cultures come back.
Yes. So in the setting of sepsis still, because we were talking about antibiotics, let's say a patient comes into ED, we've given them the 30 cc per kg bolus, right? We've gotten all of our labs, we've gotten our culture, we've started antibiotics, and we gave them fluids and they're still super hypotensive. What is the next step in management? Surviving sepsis guidelines would say start a pressor. You have to start pressors, because the worst thing is you have end organ damage, meaning you're not perfusing your kidneys, you're not perfusing your liver, you're not perfusing your brain. So you have to start pressors. That's the next step. This is just from the Surviving Sepsis like guideline campaign. You should use norepinephrine or Levophed as your first line vasopressor of choice in sepsis. I'm going to say that again because I think that is really important. You have to use, and you should use, Levophed or norepinephrine as your first line pressor of choice for sepsis, or if you're concerned that a patient is septic. You're always targeting a normal MAP of 65. You should consider invasive monitoring, so like an A-line, arterial blood pressure. And then if you need to, you should add vasopressin as an adjunct. So the order of things for, again, sepsis is, if they need pressors, it's Levophed or norepinephrine, add vasopressin if you need it. And then your third line potentially is epi, or I would not do dobutamine, and we'll talk about it in a second as well. I think as a 4th-year student who's interested in surgery, I think there's a lot of things that you can do from a sub-I perspective to look good. And I think the advice that I was given, I know a lot of you have been on my service, is that you should be always aiming to perform at you should be aiming to perform above the level of your station. So what I mean by that is like when I was a first and second year student, I was already looking toward like managing patients and thinking about how clinically this would be effective. As a 3, I was already thinking about, well, if I was a 4th year being on a sub-I, how would I act? Then as a 4th year, you should be acting like, well, if I'm the intern on the service and I'm the only physician taking care of this patient in the hospital, and I have some seniors to call, what would be the best management and what should I do? And as like an intern, we should always think about what my seniors are doing. As a senior or chief, I'm thinking about, well, as an attending, how would I manage this differently if I have no help or if I have a junior level like resident to help me? And I think not just thinking about management, but where your gaps and your knowledge base are really helpful. And so as my 4th year, I did a SICU rotation, and part of that was like giving plans that were evidence-based on septic patients, on management of pressors or other patients just on pressors. So I think you all should have this knowledge. And I think this should already be old knowledge because everyone had pharmacology, but it's always like a very intimidating thing when you are going into the ICU and you're like looking at pressors. Good thing is there's not that many pressors. There's only like, I don't know, how many is this? 3, 4, 5, 6. There's only 7. 6 truly, because the 7th one, like Millerone, like we'll go over these, but like Millerone is only for cardiac patients primarily. Isoproterenol is pure beta, but that's not even legal in the United States. We're not even using that. And dopamine is like a never use kind of like, you should never be using dopamine until like the patient's dead. So really, you don't have that many to choose from anyway. Okay, so we're gonna go over this really quickly. Dobutamine is your first line pressor of choice in cardiogenic shock. It is more beta and it's cardioselective beta than alpha, so it does increase your ionotropy and chronotropy. So it is a great drug of choice for cardiogenic shock. Dobutamine's drawback is that because it's so good on acting on the heart, it can cause you to have ventricular arrhythmias. So we really don't want to use it if we think that we're going to give the patient some type of arrhythmia like VTAC or VFib, which is deadly, right? So we don't want to use it unless we really have to. But if they're cardiogenic shock, it's a great drug. The studies will show evidence-based wise that you can titrate this up to 20, but that 95% of patients will respond to a dose of 5 to 15. If you're having to push them to that last 5 micrograms per kilogram per minute, you're doing too much. They're not going to benefit it, and your risk of pushing them into dysarrhythmia is too high. So 5 to 15 is kind of where my comfort level is, and I think most attendees would be there as well. But again, dobutamine, first line pressor of choice for cardiogenic shock. Cardiogenic shock. Millerone is a cyclic AMP. So it increases cyclic AMP. It's like a phosphodiesterase. It's like phosphodiesterase 9, I believe. So it increases vasodilation primarily in the coronaries. Again, used in cardiogenic shock. Downside is it can induce hypotension, like severe hypotension. So I've only seen this used in the setting of like, you can use this for like pulmonary hypertension, but also like very sick cardiac patients post-cardiac surgery. Isoproterenol, like I said, is not even legal in the United States. You're not going to use that, but it's pure beta. Vasopressin acts on B1 and B2 receptors. B2 receptors are in the distal convoluted tubules in the kidneys, and that'll cause for increased absorption of like water. So it does help with that, but vasopressin just as a neurogenic drug, usually patients that are super sick are at a desmopressin deficit because your central like anterior pituitary is already so drained from all the stress. So vasopressin, is usually really great. And it's the second pressor that you should add on in septic shock, right? We talked about that. Phenylephrine or neosynephrine is pure alpha. We do use this drug. NICU likes to use this drug a lot. You'll see phenylephrine in the NICU a lot because you can give it peripherally, like via an IV. And so it like denecessitates them to put in a central line. So let's just start phenylephrine. It's great if you're in a pinch, you could push it. The issue that I have with phenylephrine, and I think the issue that you all should have as well, is that it's pure alpha. So it is peripheral vasoconstriction at like the most, right? It just clamps down on all your peripheral vasculature. Let's say you have an old patient and they have some level of heart failure that isn't diagnosed yet. And now you're taking a heart that's already kind of working hard because they're hypotensive. And you're now telling that heart, work harder. you have to pump against more pressure because now you've effectively increased their afterload significantly. You can push them into acute heart failure. So I don't like to use phenylephrine that much, especially within the elderly. You have to be very cautious. Certainly, I think Levophed is going to be a better medication, or norepinephrine, which is what we're going to talk about next. It is alpha primarily, but there is some beta. So you do give a little bit of support to the cardiac muscles. So it is ionotropic and chronotropic, but you're also having distal or peripheral vasoconstriction. So it's acting on a little bit of both, as opposed to phenylephrine, which is pure alpha, only peripheral vasoconstriction. Hopefully that makes sense. I'm going to say this again. Norepinephrine or Levophed is the first line pressor of choice in septic shock. So that's what we should be starting. Epinephrine. So we give this during cardiac arrest, right? Like this is like, we got to restart the heart. So it makes sense that it is more beta than it is alpha, right? Its job is to kickstart the heart. That's why we give it in ACLS protocol for asystole. We give it for any type of like shock the patients in that they need some level of like going for their heart. So epinephrine you can start as a drip. I will say if you start this, then it means the patient is very, very sick. You're not really going to start this ever. Dopamine, I am not going to talk about because we should not be using that at all. In pediatric population, so if any of you go into pediatrics, they're like the pediatric population and the use of pressors in research are like 20 years behind because who's going to be doing randomized control trials on children? They will use dopamine, but in an adult, you should be never using dopamine ever. It's just not, it's arrhythmogenic. It is completely a not appropriate drug, especially for, especially if we have other pressors that would be so much better. My quick tidbits of this, of the pressors and how to remember them is, if you just think about, and the only thing that you have to remember is Levophed or norepinephrine is for septic shock. That'll tell you what all the other drugs do pretty much. So we know that in septic shock, we need more vasoconstriction than anything else because that's what the pathophysiology is. It's distributive shock from like vasodilation. So what I'm going to do, I'm going to vasoconstrict. So I know that Levophed is more alpha than it is beta, but I know that it does act on the heart. And then epinephrine, adrenaline is just opposite of that. So it's more beta, less alpha. So now you already know the mechanism of two of the big pressors. Vasopressin, it's like desmopressin. That's completely unique. And then dobutamine, you know, it acts on the heart and it's for cardiogenic shock. It's going to be more beta, again, cardio-specific beta than alpha. And that's it. That's like, and then phenylephrine, neosynephrine is all alpha. Those are like the 5 pressors that we use pretty much. That's it. 1, 2, 3, 4, 5. So this is knowledge that you should have in any setting. And it's not very difficult to learn. Just simplify it. Just like go back to the basics.
Just, I think you want to make sure you have a sense of what's going on in the patient before you start starting them on medications. When you're, you know, especially when you're like an intern and or covering the unit or get phone calls, that kind of thing. And also, again, having a high index of escalating it or at least letting this kind of thing, if you're starting a patient on pressure compressors, you're going to let your senior know or get the okay to do that. And, you know, like for attending someone's declining to that.
Tell somebody. Yeah.
Yeah.
This is not like you should not be like a cavalier.
Check is how much they're on. Sometimes with anesthesia, especially, but like nurses, they titrate them, you know, because we'll write orders to titrate for an MAP for XYZ. And sometimes there's some nurses that are better than others and they may not tell you. And you know, it's very embarrassing when you're on rounds and you're like, oh, they're still on Levo, but you don't know how much, or you don't know how much they increased it to. And somebody's really starting to decline. Because the other thing is they'll titrate people off of, like say they're on 2 or 3 pressors, and they'll titrate one off. And the next thing you know, they're putting them back on something else, which changes really the picture of how well the person's really doing, right? So just keep all that stuff in mind when you're rounding and when you're seeing your patients and checking up on them.
Okay, very good. Now we're never going to miss a question about pressors, right? It's so easy. It really, it's not too bad. Just bare minimums and basics. If you know what alpha and beta like receptors do, right? Then you just think about the drugs. Great. Another point in the ICU, something that you should be thinking about always is if the patient is super hypotensive and they're refractory to pressors, to fluids, to everything, should we give them steroids? right? Should be given steroids. Do they need stress dose steroids? This is something that I think is sometimes often forgotten, maybe not from like the attending senior perspective, but like from a resident perspective is like if refractory hypotension, we should be trying to just thinking about giving them steroids because maybe they have some level of adrenal insufficiency, right? So that's why we're thinking about giving steroids. This is just a steroid chart because there are different types of steroids and the balance between mineralocorticoid activity and glucocorticoid activity, so like aldosterone and like actual stress steroids is different. So like if you give somebody steroids and you give them the wrong type of steroids and you give them something that's all mineralocorticoid and no glucocorticoid, it's not going to help them because that's not what's causing them to have adrenal insufficiency, right? You have to know kind of the ratio, but this is just here. Cortisol or hydrocortisone is a 1-to-1, always easy to give. If you don't have that, dexamethasone would be your next most appropriate thing to give, or prednisolone, but dexamethasone is easy and it's IV. And that's mostly glucocorticoid. That's what you want. Fludrocortisone is just all like you need salt, you need aldosterone. But anyway, not too bad.
Contraindications to give them.
Steroids, if they're refractory hypotension, no.
So like extremist kind of like.
Yes, this is the most extreme possible.
And then sequelae of giving.
Well, so cool. It depends on the patient's like clinical status and why they're in the ICU, right? So like, there's always a concern of like, you give patients steroid, what's going to happen is 100% if you get labs, their glucose is going to go skyrocketing and they may have a high white count and that it kind of complicates or muddies the waters a little bit. But like if the patient underwent surgery and you did anastomosis or connections, right? Risks of that leaking or breaking down, one of those things is steroids. Like other things are, malnutrition, smoking, like vascular pathology. But steroids are not without consequence. But in a patient who's otherwise like sick, dying, we are throwing everything at them, and we just want to make sure that we can try and save because like who cares if they leak? At least they're alive and they're leaking versus like they're just dead. So this is again and the most extreme patient population. We're not just getting anybody steroids.
And miraculous things seen at work.
Yeah, it does work.
Yeah.
It does.
But another thing I just about in terms of patient care clinically, like, it's easy to be like, oh, they're on steroids, we just give them a huge dose, that's why the white count's like this. We still have to have this massively high index of suspicion, like we're saying, about like any and everything else going on despite all of that. Because I think a lot of people get kind of lost in, it's kind of, oh, well, we expect that because they got this too. So you have to actually probably have to be more nuanced eye of like when you're looking at people because you're not going to have the usual parameters to follow.
And things like I said are very non-uniform at that point. So you have to be like overly thinking about things. MTB, we're gonna go over this break shortly. When we do MTB, massive transfusion protocol, that is something we think the patient is gonna need a massive amount of blood products. And usually at a hospital, that's anywhere between, sometimes it's initiated as soon as they get 4, sometimes ours is like, we consider like 6 units. 10 is what some literature will say, but it's kind of dependent on the hospital's like protocol. Our MTP is like anything over, I think 6, or we think we're going to get more than 6 products of anything. The blood bank at the hospital, if you call MTP, releases untyped, unscreened units of blood. So this is like we're just dumping blood, and we're going from like the least caustic like blood type. So we're not giving you like AB positive blood, but that's stupid. I mean, the last like that has all the antibodies. Like we're giving them, O negative blood to like O positive blood to the most common blood type would be like A negative and A positive. So we're like exhausting all of our resources up until like each one. Because like blood transfusion is not without consequence as well, right? You can cause transfusion reactions, you can cause TRALI, so transfusion related acute lung injury, you can cause them to go to anaphylactic shock. Like blood transfusion, if we have to give it, we're giving blood that we are thinking is going to be the lowest risk for that patient. So they give you untyped, unscreened blood. They'll release and start thawing 6 units of PRBC, 6 FFP, and pooled platelets. A pool of platelets, which is like a big bag of platelets, is 6 units. So that's like what we're getting in from the blood bank, and they're just going to keep dumping. Some things that we do during MTP that have been shown to be mortality benefit. So there's 2 trials. One is the CRASH 2 trial. This is the use of TXA, so tranexamic acid, and giving 2 doses, an initial bolus dose and a follow-up dose, has been shown to decrease mortality upwards of like 15 to 20%. So that's why I'm always, if you hear me in the trauma bay and I'm like leading the cause, I like get give them TXA, just give them TXA. It also has been shown for benefit of mortality in brain bleed patients. So if they have a subdural, it doesn't, regardless of GCS, if you think that their like the brain bleed is evolving or worsening or of some level, like this is an acute insult, give them TXA. And this is just the trial. You guys can read up it later, but it's a landmark trial in trauma. The other thing that we do now is a transfusion of products of 1:1:1 ratio, meaning we give 1 unit of PRBCs, 1 unit of FFP, and 1 of platelets, and that should be our ultimate goal. We may not give it all like 1:1:1. It's like 6 units of blood, 6 units of FP, then pool of platelets. But our goal at the end of the day is to give a ratio of 1:1:1 resuscitation, as opposed to like 2:1:1, like 2 units of PRBCs, 1 unit of FFPs, 1 of platelets. That again has been shown to be of benefit for the patient. It's or less less harm or no harm. Excuse me, it's not less harm, but no harm. So this was the study, it's called the proper trial, that showed that 1:1:1 ratio showed the same benefit with, even though we have more plasma volume with 1:2, and it's more readily available. And there's other trials showing that. So a 1:1:1 ratio should be our benefit. There actually was, I think, a mortality difference between a 2:1:1 and a 1:1:1. So giving twice as many PRBCs, or just packed white blood cells, versus giving plasma and FFP. And the thought process behind that is you're not diluting your coagulation factors as much if you're giving 1:1:1 versus like 2 times as much packed red blood cells, which is just red blood cells, than like coag factors. Hopefully that makes sense, right? So logistically, it makes sense to just, you have to do evidence-based medicine, which is why the trials and stuff.
Just a brief sentence about, let's say, outside of massive transfusion, kind of your indicator of when you give blood, I would see platelet.
So, I mean, there's a lot of indications, but for hemoglobin drop, for packed red blood cells at least, we want hemoglobin above 7, right? That's different for cardiac patients, because if they're a CABG patient, their oxygen carrying capacity, because of their already like coronary artery disease, is at like an all-time high. So you want their hemoglobin actually above 10. So that's what the literature shows in terms of benefit. I mean, FFP and platelets, there's a lot of indications. FFP can be anything from hemophilia to bleeding disorders. I mean, if you have von Willebrand's like disease, then there's like different subtypes. So like type 1, it's just to give them like desmopressin, because that helps to release some of the von Willebrand factors, or just like FFP. But there are a lot of different indications, and I think that's a little bit, they're very broad, but blood for sure is hemoglobin of 7, cardiac patients should be above 10. FFP, depending on the situation. Platelets, if they're thrombocytopenic and you're trying to do like surgery on somebody and they're less than 50,000 units, yes. Neurosurgery, it's like if they're less than 100,000, because neurosurgery and like brain and lumbar surgeries are just higher bleed risk. Otherwise, if they're completely asymptomatic, but they're kind of like having ecchymosis things, like you could maybe transfuse above 25,000. If they have ITP, like idiopathic thrombocytic purpura or whatever, or like TTP, like they're gonna have a consumptive kind of coagulopathy. You wouldn't just transfuse them even though they're thrombocytopenic. You would have to do, like, unless they're symptomatic, you would need to transfuse, but you would do you treat it differently. Steroids, then potentially more transfusion, then surgery, also transfusion. That's
So the most important thing is to know them, right?
again,
Know them, especially when you're doing
out of my list.
what.
No, I'm saying like to know about ITP, because like
Oh,
that's
yeah.
out of the scope of it.
Yeah, most important thing is to know, right? So like if somebody's declining or somebody needs surgery or needs to go back to the OR, you want to check that. Or if they are just an ER patient needs to go to the OR, you want to know. And then decide accordingly if they need something based on what that is. And then, of course, like we'll probably talk about like that whole triad of death with like the,
Oh, I don't, but
you know, they get coagulopathic. So you have to keep an eye on that. But I think we don't see it as much now because of the aggressive sepsis, initiation measures from the get-go. Because back in the day, people used to get, we would miss sepsis and they'd get under resuscitated and they'd get that whole triad and they'd be coagulopathic. And sometimes that'd be like some of the first thing that you see, and we have to like action on it.
well, for trauma, I mean, we do have a lethal trial as well. I mean, that's just talking about a patient that is super sick in the OR. The whole cycle is like each one of these things feed into each other, and that's a triad of acidosis or acidemia, because as your pH decreases, your enzymes and your coagulation factors aren't functioning as well, right? Hypothermia, so when you're also colder, your enzymes and things don't work as well, and binding capacities aren't the same. And then coagulopathy, so that's things as easy as we gave too much blood and we're diluting their coag factors. So that triad is definitely lethal. And I think the fourth thing that they're looking at now is like hypocalcemia, because calcium in your blood is really needed for a lot of enzymatic activity. But definitely the lethal triad is acidemia, hypothermia, and coagulopathy, and those patients just do poorly. I am going to continue on cardiovascular, but I have a whole home thing with acid base that we'll maybe schedule another thing for. So we'll do this, and then I know Dr. Aaron asked me to talk a little bit about sort of trauma and fellowship and sort of residency and other advice. I think that would be too. Hypertension, I think everybody should also know how to treat, and it's not like hypertension like your bread and butter. You see somebody in the clinic and they're slightly hypertensive or starting orals. This is your what used to be classified as hypertensive emergency and urgency. There's a new sort of JNC, it's like 9, I believe now, that is not really, that's looking at like what is considered hypertensive, but now it's not really like the categories of urgency, emergency. It's just like hypertensive crisis and how we manage it. But I kind of like the emergency, where emergencies are like systolic blood pressure cutoffs. But regardless, how do we treat hypertension when it's like systolics in the 180s and 200s? That's what we're trying to treat in ICU, right? That is deadly. For hypertension, there's drips. We always give drugs via the IV because they are kind of immediate. We can titrate them, and they have much more bioavailability because IV drugs have 100% bioavailability versus oral drugs that have that first pass to the liver or metabolism. So pharmacokinetics come back into play that you guys didn't think we have to think about again. But different drips for hypertension. Nicardipine is a calcium channel blocker. Super easy to use, super fast onset, offset. It's pretty clean. Your max dose is 15. You can titrate up in as little as 1 to 2 to 5. It's a good drip, and it's profound effect on just blood pressure. So there's not really many side effects, like it doesn't make your heart rate lower, it doesn't make any, it's pretty great drug, it's pretty easy. We use that pretty readily. And even in this surgical ICU, we do, especially if we do like carotid surgery, where there's the carotid ball that causes patients to be super hypertensive after surgery. If they're coming in at a AAA, right, we have to treat that either surgically or we have to treat that medication wise to at least make sure it doesn't rupture. Aortic dissections, vascular dissections. So I think surgery is great. This is another plug in oil over here, but like it's not just cutting, it's we have to know a little bit of everything, right? So blood pressure is also one of them. Esmolol and labetalol, so we can use either. You, I think, have all heard of labetalol because we give it PRN on the floor. So we got like hydralazine or labetalol, right? That's like IV pushes. Labetalol is green as a drip too, except that it does cause quite profound bradycardia, excuse me, because it is not really, it's not really that specific. It can cause bradycardia. So we have to be very careful when we use that. Esmolol is really great too. You can titrate. No, I'm so sorry. Excuse me, makes sense. Esmolol is cardio-specific. It causes bradycardia. Excuse me. Esmolol is great that we use if we need to do what's called impulse control. So if somebody has an aortic dissection, meaning like the layers of the artery are coming apart, we want to make sure that blood pressure isn't too high, but we also want to make sure that their heart rate is not too fast, because that impulse, that wave of pressure that is being transmitted by the heart down the big blood vessels will cause that dissection to grow if it's not well controlled. So esmolol we use for heart rate control and blood pressure control. Labetalol we use because it's less profound bradycardia risk, but there is still some because there still is some, it's a beta, right? So we have to make sure that we are not, we're still monitoring them from like a cardiac standpoint. Nitroglycerin is okay. I mean, I don't think that we use that very readily, or nitroprusside. Nitroprusside, the whole thing that you may get tested on is that it has cyanide toxicity. So like their breath smells like garlic, and how do we treat it? We can give sodium nitrate, the hydroxy cobalamin, or thiosulfate, sodium thiosulfate. Mechanism, I like to know why I'm getting the drug or how it acts. So thiosulfate is a sulfur donator, so that binds it helps with the proteinases for metabolism, and then hydroxycobalamin is actually binds intracellular cyanide. So I don't know, just And then phentolamine, we use this a lot in endocrine surgery. This is a non-selective alpha antagonist. This is for like pheochromocytomas, which we do see, but it's non-selective alpha. So it's all a lot of peripheral vaso dilation. Arrhythmias, very quickly. We treat this like ACLS protocol. So I know it's silly, I think y'all take ACLS and then like, we do codes and stuff. You have to know the algorithms. So if I were to ask you all, somebody is in SVT, supraventricular tachycardia, what drug do we give? Adenosine. How much and how fast? First of all, as fast as possible, somebody do that. What is the dose of the drug? Didn't think you're gonna get pimped on ACL and stage one. So we have to know all of this. Surgery is not just cutting, we're not procedural. So 6 and then 12. 6 and then 12. 6 and then 12. Yeah, okay. If I said somebody was an asystole, what drugs would we give? There's only one drug we give an asystole. Epi, right? We give epinephrine. Do we shock asystole? No, so contrary to all the television shows, we do not shock asystole. What other arrhythmias do we give epinephrine?
Was it
There's a lot of them. VFib, okay, what else? There's another V something. VTAC, right? Great. Yeah, so VFib, VTAC, we do, there's like a cycle of things we do, right? We do shock, compress, epi, shock, compress, and then what's the next drug? Amiodarone, which is an anti-arrhythmic, right? And the dose is 300 bolus to start to load them, and then 150, right? So 300, 150. What if we don't have amiodarone? Any of you watched the old ER show with George Clooney? They always gave lidocaine. So you can't give intravascular lidocaine, 10 milligrams per kilogram. So, for severe profound bradycardia, what would we do? Oh no. Atropine, right? Atropine. And older individuals, they're not going to have as much of a response because their baseline sort of vagal stimulation and sort of sympathetic system is already depressed. So atropine may not work the best for them, but yeah. And then if they're super bradycardic and they're super unstable, then we take cardiac. But yeah, we have to know about arrhythmias and ACS all the time because we do see them. These are just some of the arrhythmias for your pleasant review. We have like the type 1 and type 2 mobits and sort of, what is it? Like dissociation with your bundle branch blocks, that's what I'm thinking about. But yeah, we have to know all of these as well. So review your ACLs right now. And then I'm gonna stop here because this is like also like another place.
Before you start,
Here we go.
I didn't get a chance to introduce you.
Oh, yeah.
Gerald. Yeah, you're resident then.
Now let you.
One thing about him is he is like very meticulous. Always a step ahead in terms of what he knows about his patients, and pretty much everyone else is. And an ardent advocate for his patients. And so I think really an outstanding example of just, not just a good surgeon, but a good doctor. And so, I appreciate that. And he's always very dedicated to teaching any and everybody whenever it's kind of like just a part of his persona. I think that's even me, right?
Yeah, that's me.
Yeah. So,
Yeah.
I wanted him to share a little bit about his journey. I think it's super inspirational and I appreciate him sharing it.
I think before the fellowship stuff, I think for all of you, I think the biggest advice that I can give you all and I already said this before, but I'm going to say it again, so the repetition of the keto without learning, that's what I'm saying. The other thing is like practice makes permanent, it doesn't make perfect. So like just because you practice it 100 times, you have to do it the right way and what's not the right way. So don't take shortcuts in life. That's my advice to you. My biggest advice that I give to y'all is a couple things, which is, always aim to perform above your current station. And I think I can't say that enough because I think it's just done me so much good in not just like, not just in medicine, but just like in terms of like education, which is like, I know it's easy to fall in that, like, I'm a third year student, I'm a fourth year student, I'm only going to study for my step 1, I'm going to study for my step 2. I'm just going to do my shelf study. if you just did the bare minimum, I don't think that you're doing yourself or your patients, the best, like you're doing them a disservice, you're not doing the best that you can. I think you should always be thinking ahead, and I think that's served me really well, like, as an intern, I'm always thinking about what my third year, like trauma senior would be doing, how would they staff this consult, what's the management of this patient? And that thinking and that sort of philosophy has always helped me to identify areas where you could do more reading and you can do more improvement. And I think that's what you should be aiming for, you should be striving to improve every day. And especially as a student, because you have the sort of uninhibited, unlimited potential to just read and improve. You have a lot of time. So that's like one advice. My second advice to all of you, just from like a resident perspective, is when you're looking for residencies, and I've given some of you this talk, I think it is so, so important to look at and identify in yourself what you need in a training program to be successful. I think there's a lot of things that we get caught up in, even I did when I was a student, just like name and caliber of program, and it's like super academic and, you know, oh my gosh, like they match at like Harvard and stuff, but I think everybody learns very differently, and I don't think that 100% of students, I don't think the majority of students learn the best in a purely academic, research-heavy setting where it is not really hands-on. Like for me, personally, when I looked at residence programs, it was a compilation of a couple things, and I think our program obviously fit a lot of those things, which was a smaller based program where you're going to get a lot more individualized teaching. And for me, that worked really well. And it's not for you, that's okay. But for me, I was looking for that. And I looked for somewhere where you're going to be very close to the attendees, because I think autonomy comes from you being close to your attendings, having to rapport with attendings, and then knowing exactly where they can push you. So my goal was always look for a residency program that was about 3 to 4 residents per year. The other thing I really looked for was a community-based academic affiliated program. So like we're obviously Mount Sinai Hospital or community, but we're UIC, University of Chicago affiliated, because I think you have the best of both worlds. You have all of the academic resources and affiliation, but at a community training program like this, where we have no fellows and we have little to no resources and we're having to do a lot of random nonsense work, I think you're going to come out of this type of program or a program similar to this with so much knowledge and so much, what's the word that I'm looking for? So much resourcefulness that no matter where you go, you're going to succeed. And I think we see that even now when we rotate at Northwestern and other sort of more active. I think the last thing that I think you all should look for in a program is autonomy, whether that be clinical autonomy or operative autonomy or some local autonomy, because I think what breeds growth is discomfort. And I think being at this program, it's not that we've always been like doing the same thing over and over again. It's that we've been pushed to do things that we're uncomfortable with. And it's because we've had the opportunity to manage patients on our own, or we've had the opportunity to operate in OR without an attending because they come in time out and leave. And it's, I think, those experiences that make for a good training, regardless of name or location in the country. I mean, I'll tell you, I interviewed at like middle of nowhere, Louisiana, like in Shreveport. I interviewed like Phoenix is not like middle of nowhere, but to me it's like Long Beach, Phoenix, so it's fine. Like Boston, here, like Northern California, but like middle of nowhere, like close to Detroit, but not in Detroit, like, you know, Michigan. And it's like programs that I think that churn out really great residents that are so competent. You know, I think I can speak for myself, Jared, Justin, and John, like all the 5th years. I think there's very little that we would feel uncomfortable operating on from a general surgery sort of realm and perspective, just because of how much we've gotten to do and see here and gotten to manage. And I think with that, you know, with this type of program, with your competency or your comfort and with your close relationship with your attendings, that is kind of what really helps when you apply for fellowship. And so I think for me, you know, I initially applied thoracic surgery. Match rate was low 50s. I did match thoracic. John, who's one of my co-chiefs, matched thoracic at his number 15, 16 ranked on his list. That's after him doing 2 years of research at Columbia with pig models and transplantation. That's with him with letters from people from Columbia, like their chair, a competitive year. And yes, I was initially like very distraught, but you know, I love trauma, I love the flexibility of critical care. I love critical care. I'll say it again, I love critical care because I think it does what I think what all of us really love to do, which is like doing the medicine of medicine. But then you also get to operate and also you can do trauma, but also it's like everything. You just get to do everything. And I think, you know, for fellowship, it's like I applied 3 months late. Interviews were like kind of already done or very tail end of it. But coming from a program like this where you're competent, coming from a program like this where your attendings know you so well and advocate for you. I told Shang and Vafa, and within like the day, I was already getting an interview invite from like everyone in the city. So like Northwestern, Loyola, Cook County, UFC already like wasn't accepting me this year. So like, that's fine. And then Chang and Vafa sent out some emails and within the week, like I had 20 something interviews. And then when you do interview for fellowship, what's really great is you tell them about your experience, which is like, we do so much penetrating trauma. We do trauma attending house, which is what I am today, like on call. And it's like kind of unheard of. And they like talked about, and they talked to Chang, you know, like this is really what the experience is. And you're like a really desirable candidate in interviewing, I think. Any of the programs, I think, could not anyone that they want to because they were willing to call for me, I think, because of our experience. And it ended up working out really well. That I naturally my number one, which is in Stanford, California. They're less trauma, they're more critical care. But I think I had enough trauma. I think Dr. Vafa will always give the best advice, which is, you know, you come from a program like this, what you want for your future training is a good balance of the other parts of what you're going to see in the future. For us, it's like the ECMO. I want the transplant patients. I want the more complex critical care. They still do trauma, they still do, but they do everything else, but the focus is critical care. And so it's kind of like the balance of what you want in your career is what's going to make you the best overall surgeon, right? And I think part of that starts when you're a student now, which is being very honest with yourself about where are my deficits? How can I get better? How can I improve? I think if you're not thinking about your skill, your knowledge base in that sort of respect, I think you're doing yourself such a big disservice and you're going to be a comfortable like middle ground, which is fine. I think for me, it's like, if you're going to take care of patients, you're going to take other people's lives in your hands, you should be motivated. You should want to be the best. You should want to know everything. You should want to not have to second guess yourself when you make decisions. It's my philosophy too.
So never give up.
Never,
And
never surrender.
even like phenomenal things, right? And I think he still wants to do Jurassic. He'll be able to do whatever he wants,
I want to say half a month to do
but now he's got like even,
surgery and then half a month to
even better.
vacation, which I think everybody wants to do. I want to travel, like,
It's meant to be.
but yeah,
So thank you so much.
of course. And then I have still another section we talked
Yeah,
about. There's another
yeah,
one.
thank you so much.
Read up on
Any questions, guys?
questions, a lot of information, I know.
I think you did a great job as well.
Well, hopefully, I mean, this is like part of what goes on in our brains when we're like rounding, so just imagine like all of these things going on, and then we're also managing multiple patients and like operating and thinking about how to operate and managing like as you're working with other people, so don't take our personality or lack thereof or our harshness personally, because I think as a resident, once you start it, residency, you remember this. So like enjoy your 4th year, go through the process. And after you all match, take the time to enjoy yourselves. No reading, nothing, because all of it will come. It's just you have to, there's balance obviously, but there's a lot to surgery that I think being a proceduralist. And I always tell people that it's like, oh, you're just like better than no, like we do surgery, but a lot of surgeries are not operating. When knowing when not to operate, how do you manage somebody when you don't operate? Because it's still technically at any point you could have a surgical problem. Medicine is not going to want to take that because they know that this is high risk for them to not have to call you again, so they get you in one of their case.
And one of the most difficult things about residency is like having to anticipate and adapt to like what different attendees need, technically, whatever else. But it's actually one of the most profound and amazing things about residency, to see ways that you agree and don't agree with, or that you learn from, or you want to tweak, or just have a more like holistic experience. And when you're out, especially if you go out in private practice and you're on your own, you actually miss that, because it's just like, you're just kind of, you learned. So take full advantage of that. And then obviously never stop growing and learning. That's why it's called the practice of medicine. We all want to continue to evolve and and the robust practice or something.
It seems like you have no liability and every opportunity to learn. No, but like you have no real skin in the game, but like, I don't mean that like,
Yeah.
like in a haha way, but no, like you, from a like legality standpoint, you have no real like skin in the game, but like, obviously, yes, like all these patients are my patients, but it's like your opportunity to do as much as possible before you start narrowing down your stuff. But you don't even know if that something's gonna be your style until you see it, right? So like, how do you know how to do this way if you've never seen it? So it's like that saying, it's like the eyes don't see what the mind doesn't know, right? Like you don't even know what to look for. Like in a patient, you all are like, oh yeah, like they did this surgery. So we're thinking about all the other complications that we have seen that you all haven't seen that you're not thinking about. So it's like you have to see everything as much as you can, and then you can start narrowing down. But if you start with a narrow view, never then life ends. Okay, very good. It's 7:30. Let me go home.
Thank you.
Thank you.
Well done.